Oh my gosh, runner's knee. I think this was the one I started on. So again, if you guys were on, you could have yelled at me probably 3 different times there and we would have found it. So Karina did patellofemoral pain syndrome, also called runner's knee. Also sometimes it's chondromalacia. So again, runner's knee is a very broad term. It could be any of these really different injuries. So oh, just like you said, broad term used to describe any of several conditions. So some of those conditions, patellofemoral pain syndrome. And this is, so again, patella, your kneecap, femoral being the femoral, and we're talking about the femoral notches here. So these, the heads or the condyles of the femur here, right in between them, there's kind of a notch, and that's where your patella will track, we call it. It'll move up and down, and it should move up and down if everything is functioning right. So it's that groove. So this can occur when the patella rubs against the femoral groove, or there's reduced cartilage in the knee, especially where the knee connects with the lower end of the thigh bone. So if, let's say, I had my quads and my vastus medialis. So again, the vastus medialis runs right here on the medial side and connects to, again, the patella through this patellar tendon, well, quadriceps tendon up here anyway. So if I have very strong inside muscle here, my VMO, it's going to pull my patella a little bit to the medial side. So every time I run, I extend my leg, it's going to track, instead of straight up and down, it's going to track to the sides. So we don't want that, obviously. That's what's causing some of this pain. So if I have a big imbalance with my quadriceps muscles, that can happen. So that's that patellofemoral pain syndrome, which can be considered runner's knee. So some of the mechanisms that this, or causes from this, right? Overuse, bending your knee again and again, or a lot of high stress exercise. So again, running is a lot of times that high stress and the bending your knee over and over again, right? Direct hit to the knee. Okay, so something can kind of throw things out of alignment with a direct blow. The bones aren't lined up right. So again, maybe it's just how someone's put together. Maybe it's something that caused their bones to be misaligned, but it can do these things. Problems with your feet. Nice. So even, and I want you guys to, I think somewhere in here, yeah. So poor flexibility and strength at the top of the kinetic chain. This idea of the kinetic chain is very important. Kinetic chain means everything is linked together. So all the way from my feet to my head. So if I have bad mechanics with my feet, it could throw off something all the way up towards my hip. Okay, so if I have bad mechanics with my feet, let's say I have really flat feet, it can cause a lot of knee and even hip issues. So the knee, the issue might be with things that are happening at the knee, but it also might be something like your foot, or this idea of falling arches. Okay. Weak or imbalanced thigh muscles. So I talked a little bit about that one with the quads. Probably one of the most common knee pain issues is quadriceps imbalance or weakness. Chondromalacia patella. This is where we have a breakdown of the cartilage underneath the patella. So again, that patella moving up and down every time we extend our knee, right? So when that happens, there's a lot of rubbing potentially. So that articular cartilage underneath my patella can start to wear away. It can kind of cause a clicking and irritation also. Okay. Signs and symptoms. So of course we've got pain. It's kind of runner's knee is, patellofemoral pain, or there's some other issues like our IT band that can cause it. But usually there's going to be this dull-ish pain. Okay. Good. Usually in front of your kneecap. Could also be around or behind it. So again, it's a very broad term for this runner's knee. When you bend your knee or walk, squat, kneel, run, or even get up from a chair. So anytime you are extending that knee and there's pain, could be something like this. Walking downstairs or downhill. Again, we have that eccentric contraction that puts more stress. Okay, if it's tender or if there's swelling, could be other signs as well. Good. So again, unfortunately, biggest thing you can do, rest. Rest and then solve the problem. So of course we can do this rice. So again, rest, ice, compress, elevate. It's going to help. But really specific exercise or physical therapy to restore your knee's full strength and range of motion. Usually fixing whatever is the issue. If that's an imbalance of muscles, that's the biggest thing we can do. If that's, we have really flat feet, maybe some orthotics would really help that person. So really solving the problem is how we can fix this. And finding the problem can be difficult. It's sometimes hard to see what is the issue. And that's why people go to school for so long. That's why orthopedic doctors, they get a lot of experience at it. I can find little minor things because I have training to do so, but I'm not perfect at it. There could be many things that I'm not seeing. And so biomechanical analysis and looking at this whole kinetic chain is really what we need to do a lot of the time. Surgery may be recommended if things like cartilage damage or kneecap needs to be realigned. So sometimes that's the answer. Hopefully not, but sometimes that's all we can do. So prevention, keep your muscles strong, limber. So again, stretching, making sure that your muscles are in balance. It's, don't do one exercise every day and forget to do the opposite muscles. So again, we talked a little bit, you had an assignment on agonist versus antagonist muscles. If I do tons of leg extension workouts, leg extension machine, but I never do leg curls, I'm going to really grow really strong quadriceps, but weak hamstrings because I never do them. So making sure there's a balance between those muscles. Use shoe inserts if you have problems. So again, if you have really flat feet, maybe you need some orthotics. Warm up before you work out. Knee braces if you need or have an issue with stability of some sort. And then mobility and flexibility exercises. Good. Awesome job, Karina. That's a good presentation. Okay. So again, that's your runner's knee. It's kind of all inclusive with a lot of things. So just know some of the basics. All right. Now our apophysitis injuries. I know someone had Sever's disease on here. So I'm going to go to that one. Sever's. Awesome. Yes. Yeah. So on here, apophysitis, before we go into these different ones, apophysitis injuries, these are where we have growth plate attachments and overuse injuries with those muscles that pull on those growth plates. So growth usually happens to preteen or, where there's a lot of growth happening. So younger kids that have a lot of activity and they're going through something like a growth spurt. So again, this one can be extremely painful, and I'm speaking from experience. I have Osgood-Schlatters, and I say have, but really it's gone. I still have a bump from it, but I don't have the pain I used to. So one of these areas is that Osgood-Schlatters, probably the most common of the three that I have on here. So Osgood-Schlatters, Sever's disease, and Larsen-Johansson's. It's really all the same injury, just in different areas of the body. So again, where there's a growth plate that's being pulled on by a tendon. So Osgood-Schlatters, and you need to know the three areas that these can happen. There's other areas, but these are the most common. I'm going to see if I can get my knee up on the table here in front of the camera. So this is my left knee. And right here, what you're looking at is this bump. Let me see if I can get it in the window. Maybe you can see it, maybe you can't. But this bump right here, that's what's left of my Osgood-Schlatters. Okay, that bump is right where my patellar tendon attaches down here. Now let me show you my other knee because it's pretty normal. I didn't have it over there nearly as bad or at all. So it's pretty flat. That's how, and if you're looking at your knee right now, that's how your knee should look. So again, I started getting that in about middle school. I played 3 or 4 sports year round, so I was always doing something, and there was always that pulling on there. So what started to happen was this tendon pulling on this bone growth plate made this bony growth start to happen. And at the time when it was happening, it was extremely tender. I remember my older brother also had this, and this was like his weak spot, and I knew it. And so anytime he was like harassing me, I'd just like judo chop him in the patellar tendon area, and he would like drop because it hurt him so bad. I also remember middle school desks had this bar that was perfect level to where if I slouched in my desk, I would hit that, and it's literally so tender. I just like sitting there wanting to cry. It hurt so bad. And then it kind of started to go away after that growth spurt stopped. It kind of just turned into a big, hard, bony outgrowth like I have now. So again, that's Osgood-Schlatters on my knee. Again, below the patella on the tibia. Larsen-Johansson is actually on the top of the patella up here. So you can see where my cursor is. It's a little growth there, and it's not usually as big as this one, but you'll get a little growth out on there, and it's really tender again. And then Sever's disease happens on the back of your calcaneus here. Okay, so in this picture, we're looking at where these arrows are, another growth plate back here, and your Achilles tendon also attaches back here. So we're going to get one there as well. So again, what it is, calcaneoapophysitis. So another name for it. Just like I said with patellar tendon, Osgood-Schlatters, it's same idea, that growth plate's being pulled on. So again, ages 8 to 15, adolescents, most common in boys, didn't know that. Makes sense, but good. This is due to growth spurts, like it said. Good, awesome. So again, that cause rapid pace of growth as well as a lot of activity. Good, perfect. Good, so the anatomy of the injury. So again, we're looking at that calcaneus and where that growth plate is. And so sometimes you'll hear the term heel spurs. Sometimes that's a different cause, but sometimes that can also be a form of this Sever's disease. Good, growth plates in the areas of cartilage located near the bone. Good, so then we have that solid bone growth that comes in there. Signs and symptoms. So pain and swelling or redness on one or both heels. Okay, so again, this could be on, if it's Osgood's, it's on the tibia there. If it's Sever's, it's on the back of the heel. So again, tenderness, tightness of the back of the heel that feels worse with physical activity or when applied pressure. So the more you use it, it's kind of like a tendonitis, but it's more the pain's coming from the bone. Trouble walking, limp, I'm guessing that should say, or on the tippy toes. Okay, so can start to kind of cause some of that pain and tenderness. Good, so stretch out a lot, because again, this is all about that pulling. Supportive shoes and inserts can help, especially with this one. Possible castings, ice packs, inflammatory drugs. So again, if we need to totally immobilize, we can put them in a cast if it's getting really bad, because we don't want to do permanent damage. And again, it can take a while to improve. Sometimes the improvement comes when you stop being so active. Sometimes it comes when that growth spurt just stops. Sometimes it comes when the body's just starting to get used to the amount of stress or exercise you're putting onto it. So that is Sever's disease. So again, 3 different types there. Osgood's on the tibia, Larsen-Johansson top of patella, okay, so the superior portion of the patella, and then Sever's on the back of the heel. All right, this is getting long. I'm gonna try and speed it up a little bit. There's a lot on this. Don't, like, if you're taking notes, don't write all of this down. It's kind of wordy. I need to change that. But talking shoulder impingement now. So sometimes this is called rotator cuff tendonitis. But impingement can happen in a lot of different areas. Shoulder is by far the most common. So what impingement syndrome means, think of it, and it kind of sounds like pinch. Impingement is, in a sense, a lot of times it's a pinching of that muscle. So in this picture here, you can kind of see the most common one is the supraspinatus. So right here, the supraspinatus comes out. It's one of our rotator cuff muscles that we learned, and attaches to the humerus. It has to go through this small tunnel here under your clavicle, or by your acromion process, and even over this part of the scapula here. So it's a tight little tunnel sometimes, and some people have a really tight bony formation there, and some people have a bigger gap and it's not as likely. But this shoulder impingement is when that supraspinatus, or it could be other muscles, gets pinched. And what happens when it gets pinched or irritated, maybe it's rubbing on a bone, it'll inflame. And so it's a tendonitis in a sense, and that muscle is getting inflamed and irritated. Okay, and when it gets inflamed, it makes the problem even worse because it has to fit through the tunnel that's maybe this big, and it keeps getting inflamed and pushing on those bones. So some causes, it's a very common one for things like over the head position. So if I'm a painter and I'm way up here painting a fence, or I'm a hairdresser and I have to hold my shoulder above 90 a lot, those are kind of the most common things. There are some other freak accidents where it can happen. Maybe I just moved my shoulder in a weird position and it pinches. Maybe I sleep on it wrong at night. There's a lot of different ways it can happen to where it gets irritated or pinched. So again, looking at this supraspinatus where it's most common, this little tiny tunnel in here, and when it gets pinched, let's say I fall on my shoulder and those bones kind of come together and it pinches it. Now it's going to swell and hurt. Okay, this is the idea of impingement syndrome here. Hope you guys are all following along here. I know it's getting kind of long here. I want to go through at least the rest of your guys' PowerPoints. But let's finish up this. Another 10 or 15 minutes, hopefully, is what I'm shooting for. I'm doing it again. I know there's one in here. Maybe rotator cuff tear is what I'm thinking, because it is slightly related. Okay, maybe not. So this is our shoulder impingement. Again, most common to have that supraspinatus, but anytime that pinches, you're going to have that dull pain. It's going to be, a lot of times it's like, oh, I raised my arm to here and now it hurts. Ow. Okay. Because of what that supraspinatus does. All right, carpal tunnel. I'm going to go to presentation because I think it's on here somewhere. Carpal tunnel. Yeah. All right. So Zoe did carpal tunnel for us. She did a very good job with this presentation. So again, carpal tunnel, maybe you've heard of it. And this is more of a ligament issue, but I threw it in muscular because it also has to do with how much you're using your wrist muscles and your forearm area. So carpal tunnel, you've probably heard of it. What is actually happening is this transverse carpal ligament. So this picture that Zoe provided us here, it actually starts to tighten. So if I'm using my hands and wrists a lot, that ligament starts to tighten and get shorter and shorter, and it starts to push on things. And the real big thing it starts to push on is this median nerve. Okay, so if I'm using my wrist a lot, maybe I'm again painting, or I'm doing typing a lot. Maybe you've heard a lot of people like, oh, I've been typing so much, or writing in English, I had to write a paper by hand or type a paper, and I've been doing it for hours and I'm gonna get carpal tunnel. People use that a lot as like, oh, I can't do it anymore. But that excessive use tightens this carpal ligament. So here's another one. So some signs and symptoms that you might be getting that tightness is a tingling or numbness in the hands or all fingers. Again, this transverse ligament is pushing down on that median nerve, and it can send kind of pain signals up, like a tingling or numbness. It could cause a weakness in the hand. Maybe grip strength isn't quite what it used to be. Your hands fall asleep often, cutting off blood flow. And then, again, loss of grip can happen there. So again, this is what some carpal tunnel could look like here. So we're looking up in here. It's kind of that compressive factors. So again, occurs from those repetitive. Yep, so nerve is affected because the median nerve is getting pressed on. So again, we see that compression of a nerve, the median nerve, carpal ligament is tightened, and we could see some swelling in there. So treatments. Again, big one with almost every injury, rest. We can do things like apply a cold pack for the pain. We could even use some heat if we wanted to stretch it out. Stretching should be done. So it's really a matter of splint. It would be another really big one. If we're, let's say, typing on a keypad that is flat and there's nothing there, that can cause an issue. You'll see these ergonomic like little pads you can set your hands on, so you don't want them bent too much up like this. And so it's just working to kind of keep your alignment straight so that you don't have as much stress there. Good. So if we still have issues when we're doing things like splinting or using some non-steroidal anti-inflammatories, which would be like ibuprofen, and these things aren't working, then we have to get a little bit more serious. So Zoe did a great job kind of outlining some of the things that happen here, some of these things that I don't even know. So next, the doctor will insert a thin needle electrode into the specific muscle to evaluate the electrical activity. So again, they're putting something in there that's basically touching the nerve and seeing if that nerve is sending signals through this compression. If this is compressed so much that I'm not getting signals, I might have things where I can't move my fingers or I can't feel what's going on. So that would be a big one to know, what do we need to do next? Is that nerve conducting electrical activity or signals? Okay, so that's going to help consider what they need to do next. So in worst case scenario, they're going to have to do surgery. That surgery, essentially, they'll go in there, look around. So that's what an endoscope is. They're looking inside the body with a camera. They're going to take a look at that carpal tunnel, so where that nerve and tendons go through. And then if they decide it is an issue, they'll actually cut the ligament. Okay, so they'll cut that ligament right here, that transverse carpal ligament. They'll cut it to release some of that pressure on the nerve and tendons. So it's fairly simple, but it is kind of a tough one. There's a lot of tendons and things going through there that we need to make sure we're not doing any damage. So prevention. Sleep with wrists held straight. Some people do kind of sleep with them under, and that can put more stress on it. Avoid flexing and extending the wrist repeatedly. So again, if you have a job where you're doing a lot of flexion or extension of your wrist or typing, all of this is causing that area to potentially tighten up. We do see this more in older individuals, and that's because their ligaments, they'll tighten up more from this excessive use. So we need to really be careful with how we're performing these activities and making sure we're stretching it out and making sure we're not doing too much damage to the area. Ooh, here's some good activities that maybe put you at greater risk. Milking cows. So all of you milking cows, don't get carpal tunnel. That's a funny one. So again, lots of different things on this list here that could cause you to be at higher risk. Yeah, good disclaimer, only if you do it over and over daily and does not happen to everyone. So it's not an excuse not to write your English paper, okay? All right, we're almost done here. We got two more. So rotator cuff tears. So some of these rotator cuffs that we talked about. So rotator cuff is made up of 4 muscles. Okay, so your supraspinatus, we talked about with impingement syndrome, it's one of your rotator cuffs, rotator cuff muscles, I should say. We've got our infraspinatus, basically on the inside of our scapula, on the top side. We have our teres minor, same area, and then we have our subscapularis. Those 4 make up your rotator cuff. So any of those tear, it's going to cause not only pain in your shoulder, but also some issues with rotations. I've had pitchers who have torn a rotator cuff, and they're going to have pain as well as decreased accuracy when they throw, things like that. It can also sometimes include the long head of the biceps tendon that comes up through here. So that's your rotator cuff. A slap tear is more talking about the labrum. A labrum is, think of it like the meniscus in your knee, but for your shoulder. So it's basically the meniscus of your shoulder. Somebody's got rotator cuff tears. Let's look into this one first. So True did rotator cuff tears for us. Perfect. So again, here's those 4 muscles that make up our rotator cuff. So again, that holds that socket real tight. Okay, it attaches the humerus to the shoulder blade and helps to lift and rotate your arm. There's a lubricating sac called the bursa between the rotator cuff and the bone at the top of your shoulder. So we've talked a little bit about bursas, I think, in this class. So that bursa helps to reduce friction and tension, kind of functions similar to the labrum. Bursa allows the rotator cuff tendon to glide freely. Okay, good. So here's some really good pictures here. So here's our 4 rotator cuff muscles. So if you're trying to throw a baseball or throw anything, you're using rotator cuff muscles. So located on the head of the humerus, typically in the supraspinatus. So again, here's these bursas also that are on there. I think that's a cool one to include on there. So something like impingement syndrome too, these bursas help to prevent that. Oh, look, here's a picture of impingement syndrome. So again, that bursa is helping to relieve friction. Good. So how do you tear it? So we have partial tears and we have full thickness tears. So obviously both are bad, but we want to stay away from those full thickness tears. Those ones are the ones that a lot of times require surgery. So you could have it from falling on an outstretched arm or lift something too heavy with a jerking motion. So it's that idea of your muscle going from relaxed to flex really quickly. That can kind of cause some of these issues. Degenerative tears, so wearing down a tendon that occurs slowly over time, and maybe that's because of some of these bony structures that it keeps rubbing against. That can cause it to kind of break down and then tear. I've also had, so like pitching in baseball happens a lot, and if we look at the difference between baseball pitchers and softball pitchers can pitch, every game of the season theoretically, and their shoulder will be fine. Baseball pitchers, if they did that, they would have issues with their shoulder after 3 games in a row, if not sooner. And that's why we have these pitch counts for baseball pitchers. And softball, we don't worry as much because it's this underarm motion where there's not as much stress on this rotator cuff. So especially with baseball players, this throwing motion, you're trying to throw so fast going this way in internal rotation. What most pitchers don't work on are the external rotators. That's going to slow your arm down from going too far into internal rotation. So what happens a lot of times is pitchers are throwing so fast, 95-mile-an-hour fastballs, and they can't slow their arm down from rotating this way, and they end up tearing one of their external rotators. Another kind of common way how to tear it. Good, so here's some different forces on the body and how this can happen. Here's this idea of falling. Okay, if I'm falling and I got to catch myself, you're going to try and contract that rotator cuff to keep it stable, but there's so much pressure there that you're going to end up maximally trying to contract that muscle. So again, this idea of that inertia is greater than the force our rotator cuff can handle. Okay, so some symptoms. Deep ache in the shoulder. Okay, so this isn't going to be like, oh, I'm getting a pinch right here. This is like, it's inside the shoulder. It can hurt for sleeping. People have trouble getting comfortable in bed when they have something like a rotator cuff tear. Difficulty to reach behind your back or up your back. So one of the first tests I would do for someone who has a rotator cuff tear, or I think has rotator cuff tear, is called Apley's scratch test. It's just looking at their range of motion. So I have them reach across to their other shoulder, have them reach behind their back, see how far they can go down their back, and then I have them reach up their back this way. And that's a tough one for someone who has a rotator cuff tear. And one of them is going to be worse than the other. If they have, again, say supraspinatus tear, they're going to be bad at certain ones of these rather than others. So that kind of also gives you a hint. And then again, overall arm weakness. So good. So you're not going to really see anything different. Appearance, no visible with the naked eye. No physical changes to the skin. So again, these people look fine. It's like, okay, suck it up. An MRI though, or an ultrasound will show you usually that there's a gap or tear in that muscle. And x-rays can be helpful, just like True put on here, to sometimes see those spurs, bone spurs that can happen. Let me go up to one of the pictures with the, let's see if I can find the clavicle here. So the clavicle is a good example of a place that can get bone spurs off of the end of it. So this is a normal clavicle. It just goes straight out to here. Some people will have these bone spurs to where it kind of like hooks down into like a claw. That's going to hurt that supraspinatus, potentially causing either impingement or a tear because it keeps rubbing on it. So that claw-like clavicle that can kind of bone spur and go down like that. Good. Yeah, so that MRI is kind of, or ultrasound is needed to kind of confirm that. So now our treatment. So treatment, most athletes are going to want the surgical if it's a bad enough tear. So they can go in arthroscope. So again, that's pretty minimally invasive. They'll just use a camera and repair maybe a small incision, maybe stitch together. Or most time they have to open it up if it's a larger incision. Tendon transfer. So kind of like with the knee, sometimes we need to get a tendon from somewhere else in the body and use it in the shoulder to help repair it. A total shoulder replacement, if it's really messed up, they have to do a total shoulder replacement. Most athletes are not going to, if there's that much damage, they're not going to function with a total shoulder replacement afterwards. This is more for like older individuals. Their shoulder's so messed up from years and years of abuse that now they have to repair the whole and basically replace the joint with metal and plastic kind of joint. Full recovery after one of these surgeries, you're going to need a lot of physical therapy. You're going to be, 6 to 9 months of physical therapy to totally recover from this, depending how bad it was. Non-surgical it really depends on how big the tear is and where it is. You could have a pretty full recovery, but if it's a major tear, you're probably not going to be, a pro pitcher anymore, or, even on the side, you're probably not going to be able to pitch like you used to, or have the same function of the shoulder, whatever sport or activity we're talking about. If it's minor, and I've had athletes with this where it's a minor strain tear, steroid injection can help to kind of cause that recovery. And it's not a what's the word I'm looking for? It's not the steroid that makes you stronger. It's a corticosteroid, so it helps more with swelling and recovery that way. So our prevention, stretching. Okay, so again, it's all about stress on these muscles. So stretching can help reduce some of that stress. The bigger part, I would say, is strengthening. So again, making sure that all the muscles, and we have a balance of muscles. So again, to strengthen your rotator cuff, it's best to use lower resistance with more repetitions. So again, how you train is also important. When falling, avoid catching yourself in your arms. So again, when we have those situations where you're falling, and again, falling on an outstretched arm is probably the biggest cause of injury in sport. Okay, learn how to fall, tuck and roll. Okay, rest, ice, and then physical therapy before injury worsens. So again, catch it quick, and make sure it doesn't get worse. Awesome. Okay, that was a really good one. Really good presentation, Drew. Nice job. Okay, well, last but not least, oh wait, I want to show someone also had slap tear. That was a good one. Slap tear. So slap tear. So we talked about our rotator cuff. Slap tear is referring to our labrum. Okay, so Karina did this one on labrum. Great pictures here. So here's our glenoid fossa, which is essentially just the crater for our humerus to fit inside of. Okay, so on the outside here, you see our glenoid or labrum, our glenoid labrum. So this labrum is basically a tough tissue that kind of helps to keep our humerus in there, and when it moves, it should glide and be smooth. So what happens with a slap tear? SLAP stands for superior labrum from anterior to posterior. That's what SLAP stands for. So a slap tear injury focuses on that area. So superior labrum, so here's our labrum, superior, the upper part, and then anterior to posterior. So here's our anterior to posterior. So it's a tear right along here in this area. And so it's not a tear of a muscle. It's really a tear of this, this tissue. So again, think of this like your meniscus, but it's your, labrum. So mechanism. Injury can be the result of acute trauma, but it's usually repetitive movements that wear down the labrum over time. So again, this humerus is rotating in here, and it could be damaging it from overuse, or maybe it's put in a weird position that pinches a part of that labrum and does damage. So technique of the shoulder is very important. Ooh, good pictures here too. All right, so some weird things that the format did here, but it can be difficult to identify a slap tear because it can be mistaken as other shoulder problems. So, for example, tear of a rotator cuff. But in here, what we're looking at is the labrum itself, and this is a repair of the labrum. It looks like because they've got some stitches in here, some hardware. So the labrum could tear, and basically it sends a flap of the labrum kind of hanging off. So you could be, because of that flap, feeling things like a pop or clicking in the shoulder. And if you're feeling a lot of pops and clicks and maybe even locking, so it's like, oh, I move my shoulder this way and it just stops. I can't move it. And pops or clicks. That's probably because we've got a piece of labrum that's getting stuck in that joint when you move it in certain directions. So it could decrease that range of motion. And that's going to be painful as well. So popping, catching, or grinding. Again, we want smooth movement, and that's what the labrum does. So treatment. So really depends how bad it is. If it is a big tear, we have to go in there and sometimes stitch it back together on there. If it's just a small chunk on the outside of the labrum, they can go in just arthroscopically and kind of trim it off. And maybe in the future, if we did trim off a lot of the labrum, someone would need a full joint replacement later in life. But it can be kind of a temporary fix and usually no issues, at least for the next 10, 15 years, depending how bad it is. So prevention, again, kind of like we're talking about with some of these other injuries, is muscle balances, making sure you're stretched out, warmed up. You're not going to put your shoulder in any positions that is real dangerous for it. So just, not being torqued back in this position, or not falling on your arm and kind of requiring these weird situations for your bone structure to do damage. So that is your slap tear or labral issues. So good job, Karina. All right, last one. I know this is getting kind of long here. I guess class is long too, so now you guys got to listen to me talk again. Sorry, over there. All right, Tommy John. So our Tommy John injury, and I really just have a picture on the PowerPoint here, but luckily Owen did a real good job on his. So I think, yeah, here we are. All right, Tommy John. This is pretty cool because Owen has a picture with Tommy John. So if you didn't realize, this is the person that this surgery is named after. Pretty cool. Owen, you'll have to let me know how you got that picture, how you met him. That's pretty cool. So points there. Kudos on. So first, what is Tommy John? So Tommy John is a tear of a ligament. Okay, this is the UCL ligament, which stands for ulnar collateral ligament. So it's right here on your elbow. If you can't tell what this bone is, you see your radius and ulna here, and your UCL is right here, ulnar collateral. So that holds my lower forearm to my humerus. So it keeps it from going this way. So my arm keeps it from bending this way. Okay, this keeps it all nice and firm and stable. So that's where it is, and that becomes very important when we talk about this. For those of you that are baseball fans, you've probably heard of Tommy John, and we talk about it a lot with pitching in baseball. So, cue pitching pictures. Awesome. Most commonly seen in baseball as a result of constant stress put on the elbow by pitching. Also seen in quarterbacks and dodgeball players. Dodgeball players, nice. Global Gym Purple Cobras, dodgeball players. So these pictures are really key, and where these arrows are really helps. Especially this submarine pitcher here. He's putting a lot of stress on his elbow. We also sometimes talk about what's called little leaguer's elbow with this. When I throw a baseball, and this is a good picture to look at right here. When I throw a baseball, this weight and this internal rotation puts a ton of torque on your elbow, and specifically on that UCL ligament. So right here, this UCL ligament is being stressed greatly. And what happens is pitchers that maybe they're pitching a lot, maybe their biomechanics, like this guy, is not so good and putting a ton of stress on his UCL. Maybe they throw a lot of curveballs. Do it for a lot of people. It puts a lot of stress on the UCL because of the turning of the hand in there and the wrist. So because of all these things, it's putting a lot of stress there, and it tears your UCL. Okay, so again, like Ellen says here, either using incorrect mechanics, throwing too much without rest, having poor recovery methods can cause this injury. Awesome. So again, constant stress and deterioration of that UCL. So you're going to see swelling, less range of motion, soreness right where that UCL is. You're going to see some bruising and swelling there. So yeah, it's going to be intense too if they have had this. So the treatment, and this is where the name Tommy John comes from. This individual here, first guy that had this surgery done. This is where they're going to replace the UCL. So the UCL is removed, and then what they're going to do is kind of drill these holes in here, and they're going to put a new tendon in there. And they actually take a tendon from your forearm. Let's see. 2 bones. Yeah, so it comes from your forearm. It's actually this, can't really see it on that one. It's actually this tendon right here, your palmaris tendon, that they take, and they take it out because you don't absolutely need it. You've got so many tendons in here that can work and function the same thing. And then they thread it in here through these tunnels to create a new UCL. It takes about a year to return to top form. So again, this is going to be it's going to be a progress. This is going to be a long journey that someone has to go through if they tear this. Prevention, don't play baseball. Yeah, so reduce reduce or take the torque off of the elbow there. Right? So if you don't play baseball or throw items, I mean, you can get it from other things like throwing a javelin a lot, maybe. Or if I tried to throw a shot put like a baseball, I would probably tear my UCL. There's just too much torque with all that weight trying to go forward. Would probably snap it. So yeah, don't stay away from those kinds of things. Yeah, if you do choose to play baseball, then throw with proper mechanics. Absolutely good form so that there's less stress on here. If I'm throwing sidearm, again, tons of stress here if I'm throwing like this. Okay, so throwing over the top, straightforward. And then again, things like pitch count. Don't throw too many times. If you're throwing over 100 pitches a game or time pitching session, probably too much. Good, awesome. So I know that took quite a while. Hopefully you guys find time to watch this video, and hopefully it uploads and doesn't have any problems for anyone. Lots of injuries. This is like a week and a half of class that we just stuffed into this video. So it's not quite as much information, but it's also a lot more information, if that makes any sense. Hopefully this helps. You can watch it, you can rewatch it, take notes, but ultimately you're going to be responsible for knowing at least the basics on these injuries. Not necessarily every single thing that I've said and that has been in these PowerPoints, but at least the basics. I'm not going to make it too hard, but we will have a test on it. So sit through it, take some notes if that's your style. However you need to get it in there, make some note cards, whatever it takes to get this information into your long-term memory. If you have questions or want to talk over some of these injuries, if you have questions about these injuries, I'm going to be doing a Zoom meeting, office hours. I'm going to try and do that each day of the week. So starting tomorrow, Tuesday to Friday. So that was your crash course on muscle injuries. I'll try and get more things visually that maybe I can draw on something, or we'll be working through it. If you have issues with the video, let me know, either through Remind or email, or come to the Zoom, and let me know how it goes. Hope everybody's doing good, and I'll try and get this posted so you guys can watch it. And thanks for coming.